Good afternoon, and welcome to the Bob Woodruff Foundation's webinar featuring panelists from the Veterans Health Administration's Office of Rural Health and our very own Got Your Six Network partners. We are thrilled by the strong interest in this topic in the webinar today, and we will begin right now. I'm Macy Calvert. I'm a program officer for the Bob Woodruff Foundation and an active duty Marine spouse. And we really appreciate the turnout for this event. This has been a very demanded topic by you guys working in the fields and at a lot of best-in-class conferences. So we're excited to host this conversation today. And for those who do not know the Bob Woodruff Foundation, the Foundation's Got Your Six network is the largest non-governmental network of organizations serving our military and veteran community. The network is made up of veteran-serving organizations of varying sizes, maturity, and focus areas across all 50 states, Puerto Rico, American Samoa, and Guam. We are a thought leader, a funder, and when it's helpful to our community and when we're trying to understand thorny issues, we are a convener. I'm going to start off with level setting the conversation with a slide with some statistics regarding rural veterans, and then I'll introduce our moderator and we will kick off the panel discussion. The latest census has found that just shy of 25% of rural veterans live in rural areas. Really looking forward to what the next census sees in terms of those numbers. And just under half of all rural veterans are housed in the South, followed by the Midwest, which is about a quarter of them, and then the rest is split up between the West and the Northeast. And we have panelists representing all of these areas today, so we're excited to have that representation in this conversation. The VA has found that 4.4 million veterans live in rural or highly rural areas per those definitions, and 2.7 million of those are enrolled in VA care. We know that rural veterans are more likely than other veterans to live in poverty, and 31% of those enrolled in VA care earn less than $35,000 annually. We also know that rural veterans are more likely to be food insecure and yet consistently less likely than their non-veteran peers to be enrolled in the Supplemental Nutrition Assistance Program, which will also be a part of the discussion today. And lastly, overall veterans are more likely than their non-veteran peers to own homes, and rural veterans are even more likely to own their homes. And now I'd like to introduce our moderator. Shelley M. McDermott Wadsworth is a distinguished professor of Human Development and Family Science at Purdue University, where she directs the Military Family Research Institute, which she co-founded, and serves as Director Emerita of the Center for Families. I will hand it off to her now to introduce the rest of our panel and to start our discussion.
Thank you very much, Macy, and thanks very much for the invitation to serve as moderator of today's discussion. And I'm thrilled that there are so many people in the audience. We have three panelists today who I'm eager to hear from. The first is Peter J. Caboli, MD, MS, Executive Director of the U.S. Department of Veterans Affairs Office of Rural Health. Steve Yamamori, founder and CEO of Reveille Foundation in Arizona and Oregon. And Tim Driscoll, Assistant Director of Service Coordination of Veteran Services of the Carolinas, serving all of North Carolina, of which 80 out of 100 counties are considered rural. So obviously folks with great expertise to be with us today. Our representatives, our panelists, work from multiple perspectives, including a national perspective, the Midwest, the East Coast, and the West, including the Navajo population. So I'd like to kick off by asking panelists to say a little bit about the unique challenges and considerations for rural veterans in your community. So why don't we start with Steve?
Yes, good morning. And what a privilege it is to be on with you this morning. I'm looking forward to learn as much from this session as I am to give out some of our information. So I'm Steve Yamamori. I'm with the Reveille Foundation, and just a couple notes is that we've been serving the Navajo Nation since the outbreak of COVID back in 2019, and it started simply at just a bunch of folks being concerned. Because a little bit of information is that 60% of the Navajo Nation have no running water or electricity. And so they were one of the largest segments of populations hit by COVID. and they had one of the highest death rates than any other place in the country. And so, knowing this, we really tried to activate the community to be able to reach out and serve the Navajo Nation. We've done, and many thanks as a Got Your Six Network participant. Many thanks to the Bob Woodruff Foundation for being a major funder in our efforts to do the emergency services and food. And so, with their help, we were able to go out there. We just finished our sixth event on the Navajo Nation. It is one of the largest. It is the largest Navajo Native American nation in the country, and they have about 15,000 veterans. And the Native American population has one of the largest service ratios of the population, and they have one of the largest combat service ratios in the country. And so they're absolutely a demographic that we want to honor and serve. Those are a little bit of the particulars about the Navajo Nation in particular. They also span 4 states in the Southwest, and it's been a beautiful challenge working with them, and it's been a really an experience of a lifetime. So uh, hopefully that answered the question.
Thank you very much. Tim, how about you? Switching to the other side of the country, what kinds of things do you see?
One of the biggest things we're seeing in North Carolina is to rural veterans, but not just veterans, rural people in general, is access to broadband, right? And so we continue to have that conversation around how to increase that access. And I think later on in this panel, we're going to discuss it a little bit. The other piece is building trust within rural communities. As a recipient of state and federal funding, I have to make sure that I'm measuring the return on the investment that the federal and state government are investing in my organization with the time and distance and geography that we have to cover to talk to rural veterans. So, for example, I have to dedicate a person to drive 3.5 hours. The prospect they may see 10 to 12 veterans when I can send that same person 45 minutes and talk to 20 to 40 veterans at an event. And so continuing to have that balancing act and weigh that return on investment that funders typically look for is extremely difficult.
Well, Peter, you have to look at this picture from a higher level. So you have to have a national perspective. How do things look from where you sit in terms of unique challenges and considerations?
Yeah, I was just taking some notes on what Steve and Tim said, and because I have both the national perspective, so our Office of Rural Health, um, you know, is responsible for rural veterans everywhere. But I grew up in Iowa, in a small town, and still live in Iowa, a medium-sized town, and so I sort of have the perspective of the Midwest as well. But let me say that in our office, when we look at rural health challenges, so we can put it into 4 buckets that we divide it up into. Part of the reason we do that is that I can't think past 5 on my hand, so if I stick with 4, I can usually remember them. So the first has to do with workforce. The second is geography. The third is digital, and the fourth is social determinants of health. For workforce, there's is a constant supply and demand issue everywhere, and it's not just a rural problem; it's also an urban problem. But what we need to do is to try to figure out how we can meet the demand for workforce with the supply. The second on geography is how do you overcome distance? We all live some distance from, healthcare, but how does that distance impact us? Whether we need public transportation, we need someone else to physically transport us there, or can we overcome that through telemedicine or home care to bring the care to the patient? So, geography can be overcome in 2 ways: either bring people to where they need care or bring the care to them. The third bucket we look at is the digital divide bucket, or how do you provide telehealth if they don't have access to broadband internet? We did some recent survey work with rural and urban veterans and found that actually about 95% of all veterans have access to broadband. It's a little bit lower in rural areas, but not as much as you might think. Of all the veterans, about 90% have broadband that's adequate to do streaming video. So, when we do video visits, we need at least a high enough speed. So, but there's still about 10% that don't have it. And then of the 90% that do, there's still some that just don't have the capacity, that choose not to use it and need training or assistance. And the last big bucket is social determinants of health, which you all deal with a lot of those. We try to address as many as we can, but it's challenging because there are so many of them. I just want to say two things about what Steve and Tim said. One, Steve, you talked about American Indian Alaska Native veterans. We know there's about 165,000 American Indian Alaska Native veterans, and about 50,000 of them are enrolled. A large number of live in the Southwest, and so we have programs specifically to focus on them. And Tim, you talked about trust, and trust is something that the Secretary of Veterans Affairs, Dennis McDonough, has really been focusing on these last 4 years, and how to improve and increase trust in VA as a provider of care. And we seem to be making some inroads. There's always people that will be distrustful, but we shouldn't be doing things that make them distrustful. So I'll stop there.
Thank you. Given that rural veterans are more likely to face food insecurity and poverty than urban veterans, I'm interested in specifically how any of you are thinking about addressing the challenge of food insecurity and managing the various kinds of federal benefits or other benefits that might be available to assist them. Does anyone want to jump in on this question?
As I said, I think Tim kind of nailed it when he was talking about trust, right? Gaining trust, um, and and the other thing that I would say is when you're serving the rural veterans, is that trust is a huge key, and being able to understand that the community will tell you what they need. You don't tell the community what they need, right? And so that was a big learning for us. And I say that just to preference the fact that especially from an emergency standpoint, even though there are other food benefits such as SNAP and food boxes and um, we have some food agencies, food banks that literally set up monthly um, feeding throughout the Navajo Nation. We were finding out that in the really rural areas, people just can't drive. Older folks are just in their hogans or in their homes, and so it was really great to see other members of the community rally together and take 10 food boxes. And they said, "I'm driving out to about 2 hours from here." To be able to get to some people that can't drive themselves. And so, although there are a lot of different food options and water options. Um, Again, a lot of people, the Navajo Nation is broken up into 100 chapter houses. And so each of those chapter houses are sort of their hub of the community in those different areas. And so it's and most of those chapter houses has a veterans department inside of it. And so they really have done a good job of um, taking and segmenting the nation into the different tribal um, uh, houses. And so the tribal clans are mostly in those different areas, and they have chapter houses. They have a lot of those different resources, but there still is a gap of folks that kind of fall through the cracks.
Mhm. It's hard, I'm sure, for people in some areas of the country, like where I am, to really appreciate and grasp the vast distances that some people in other parts of the country are dealing with. So I really appreciate that vivid description. Um, Peter or Tim, would you like to weigh in with regard to food insecurity in your work?
I want to build on a couple of things Steve said, and then add a couple others. Uh, your point about it being local is really important. We've done some programs ourselves in the Office of Rural Health, but also nationally, the VA established a food security office 2 years, just over a year ago now. And one of the areas that the food security office is looking at is what are the services that VA can provide and what are the services that VA can partner with the community on. So an example is, do we want to take on the role of having food pantries within a VA facility? Well, some have done that, but that has its own challenges of how, we're a government agency and we got a lot of rules. And so managing the food and expiration dates and things like that can become very cumbersome. So maybe we're better off partnering, especially if we can partner with funding with local agencies. Um, we have worked with local community supported agriculture, and that's a program that we're trying to work more closely with USDA on so that we can share funding and sort of work together with them. That gets back to the local and how you can support not only the veteran in the community with food, but support the community. That's why it's called community supported agriculture, and provide income for those farmers who then share that food. It's interesting. I was talking to somebody that working with one of the programs, and they were talking about the pros and cons of pickup versus delivery. And obviously, for delivery, like Steve said, some people can't drive; they don't have a way to get in. So bringing food to them is critically important. But they said one of the unintended benefits of pickup was actually bringing people together and working on this issue of loneliness and social isolation, because for some people that once a week pickup might be one of the only real interactions they have with people, and meet the farmer, meet the other people that are part of the CSA. And it's not a doesn't come across as sort of just a handout. It's like you're coming together to support the community. So last thing I'll add is, you asked specifically about SNAP and other food assistance programs. One of the things that, we really stress in the VA is, using our social workers and our case managers, that again gets back to that local understanding. You can't put a social worker, call center in the middle of the country and serve everybody around the country. You have to have the people on the ground who know the local food sources, know the programs at the state level, since SNAP and Medicaid are all state programs. How do you apply? Because sometimes it's just a matter of applying. It's like we've learned, I think a lot of us have seen the stories about school lunch programs. When you make it hard for people to enroll in them, a lot of the people who need it the most just don't get it because it's just too difficult for them. So how do we reduce those barriers?
Absolutely took what I was about to say and made it better,
Correct.
right? Making qualifications for existing programs not more accessible, but digestible for the population we're trying to serve, right? Because everybody on this call knows food stamps exist. Can many people in rural communities tell you what the monthly income limit is for that benefit, right? If you tell a veteran, go apply for food stamps, there's a general belief, oh, I won't qualify. If you ask a veteran, or if you tell a veteran, hey, if you make $1,200 or less a month, you may be eligible for food stamps. That spurs that action, right? And so understanding how to make programs digestible for the populations we're trying to touch.
Thank you so much. In this next segment, I'm going to be asking each of you to say a little bit about the specifics of the work of your organization. And the Bob Woodruff Foundation asked me to begin by describing an initiative that my institute developed called Reaching Rural Veterans. And so we have tried to be very thoughtful about both the characteristics of the rural veteran population and also some of the realities that all of you have mentioned, like the need to be intensely locally focused. So the key elements of this approach are that we use food pantries in rural areas where there are substantial numbers of poor veterans as the delivery platform. And we recruit a faith community also in the local area to serve as a lead partner, specifically because we are so concerned about social isolation. We then prepare staff and volunteers at the pantries and the faith communities to be more knowledgeable about and better prepared to serve this population. This helps to deal with the trust factor and hopefully can make the pantry more hospitable to local veterans as well as other community organizations. We then assist pantries in organizing resource fairs or mini stand downs every few weeks over the course of a year And these events leverage multiple national, state, and local resources, whatever is available in that area, including the Cooperative Extension Service, SNAP-Ed educators, county veteran service officers, VA resources like mobile vet clinics, CBOCs, vet centers, and other um, mental health, housing, and employment agencies, even nursing schools, whatever we can find in that region. We also help the pantry to position and market the stand downs to veterans in the local areas so that veterans will come, thus getting veterans in the same space as benefits and services they have earned, much like was mentioned with regard to CSA, building on that same possibility. We make wellness calls to the veterans we encounter to offer to assist them in connecting to benefits and services. We've been able to implement and refine the model now in 4 states, working with a few pantries at a time. We're able to provide a small amount of financial assistance to both partners and veterans, as well as technical assistance to pantries and faith communities to support their implementation, which is probably the biggest barrier to large-scale implementation. Otherwise, so far, the model has proved highly replicable, I think because it is by definition adapted to each community. And some pantries have continued to hold resource fairs for veterans after we've completed our work with them. Results so far have shown that veterans do come to the events, and in an experimental evaluation funded by the Bob Woodruff Foundation, I also should shout out here, I forgot to do it above, we developed this in partnership with the Center for Faith-Based and Neighborhood Partnerships at the VA, and also early on received funding from the Office of Rural Health. We've observed statistically significant increases in contact with some community organizations. In multiple implementations, veterans have reported increased access to pension funds and decreases in substance use between baseline and 3-month follow-up assessments. We've not yet been able to improve some other important metrics in 3 months, but we're currently pilot testing strategies for doing that. One of the things we really like about this model is that it does try to use existing resources to their best possible advantage, such as the Cooperative Extension Service and County Veteran Service officers, while also providing a way that veterans can connect to federal VA benefits and services, which is always a priority. So with that, let me thank you for your patience and turn it to other members of the panel. Tim, would you like to start by telling us about your predictive analytics project to look at implications for other organizations' outreach efforts?
A couple of years ago, in conjunction with our technology partner, Unitas, they had come to us and said, "Hey, we have acquired a predictive analytics company, and the company that they had acquired basically assigned health scores to individuals all across the nation. If you have a cell phone, if you if you use an insurance provider, using everything from historical claims data to geospatial location, there's 5,000 different data points that feed into an algorithm weighted differently that assigns a score based on health." And they said, "We think it could be a really good opportunity to serve veterans in your communities." And the way the scoring system works is, 0, you're the healthiest person in the world, and 99, you 1 foot on the grave, the other 1 foot in the grave, the other on a banana, right? And so uh, what they did was they looked at who was currently receiving interventions, what their scores were, and they noticed that they were all in a certain range. Based on that, they said if a veteran has a score within this range, it may be the right time for an intervention. And so, targeting veterans at that range, they were able to geographically locate these veterans within North Carolina, as well as give us contact information, right? Again, anybody who has a cell phone accepts cookies. When you do that, those cookies are purchased. And so we were able to begin to proactively outreach to individuals who otherwise would have never had a true picture of the resources assessment. One veteran in particular that I can think of that we encountered very early on in this pilot, we knew that there was something here, it was an elderly, it was actually a veteran widow in Western North Carolina, an area where outside of Buncombe County is extremely difficult to reach, but also to serve veterans because there's just not much in Western North Carolina. we were able to get her heating paid, but she also qualified for DIC payments from the VA, and she never realized it. So here you go, moving an elderly veteran widow who's living in poverty and getting her an additional $14,000+ in income a year. That's life changing for these individuals, and we're performing that outreach in a very specific way. We're reaching out to them by phone, right? Because a lot of times veterans in rural communities, they don't want you, they don't want to email with you. They want you on their doorstep. They want you in their community, in their trusted access points, whether it be their church, whether it be uh, the local food pantry that they do use on a regular basis. They want you. They want that feeling of a true connection when they talk to you, and so that's what we've been able to uh, do. We have 3 staff currently dedicated to this effort, and they are moving mountains for veterans in rural communities who never realized resources exist.
That's a very inspiring story. Thank you. Peter, I know you have several initiatives within your office that I'm sure people would love to know more about. Could you say a little bit about the Veterans Rural Health Resource Centers, your promising practices implementation programs, and also your enterprise-wide initiatives?
So the way that the Office of Rural Health funds programs or projects or research is sort of through 2 pathways. Um, the first is at a national level, and the second is sort of at a regional, at a smaller scale level. So I'll start with the smaller scale level because that kind of can flow up to national level programs and projects. So at the regional level, we have 5 resource centers. We call them our rural health resource centers. One is in Portland, Oregon, Salt Lake City, Utah, Iowa City, Iowa, Gainesville, Florida, and White River Junction for Vermont. So regional, so there's some representation, but also each of those resource centers focuses on sort of slightly different areas. They can kind of do anything they want, but Portland has a focus on mental health related issues. Salt Lake City has a focus on American Indian Alaska Native issues. Iowa City does a lot with telehealth and connected care. Gainesville is predominantly around rehabilitation services in rural sites. And White River Junction has a focus on veteran suicide as well as workforce. So we have a process by which, our funding is all within VA. We don't fund outside the VA directly. So you can partner, at a local VA, but it's not. This is not an open funding opportunity for anybody. So where our funding comes from Congress. So we have a process in the fall that's just starting now, and it'll close in November for letters of intent. To just a 1-page letter of intent to say what somebody in the VA would like to work on, and then it's reviewed, and then they can be funded for 1 to 3 years after that, after the full process goes through. And then after that 1 to 3 year period, they can apply for additional funding if it seems like it's promising and can continue, as we used to call them promising practices. We've now called them rural mentored implementation programs because we feel like there's some initiatives that we've started. I'll give you an example of one. We started one back about 10 years ago called home-based cardiac rehabilitation. So cardiac rehab is a evidence-based treatment for patients who have certain cardiac conditions. Well, 10 years ago, less than 1% of veterans would get cardiac rehab. It just wasn't available. We didn't offer it in the VA, and we could pay for it outside the VA, but a lot of non-VA sites don't offer it either. And for rural veterans, especially, rural communities just don't offer cardiac rehab. And so we started that as a small project in Iowa City, and now it's at, I think, about 60 different medical centers, and spreads. So new sites come on every year. So that's what we do at a local level. Then nationally, we have what we call enterprise-wide initiatives, and these are projects that developed within the VA, but that have proven that they are effective, proven that they're scalable, but they need the funding to really jumpstart them and really spread them. And our budgets for those range anywhere from 250,000 to about 12 million, I think, is our most I mean, actually, there's a $15 million one. But those then allow us to spread nationally and then figure out how to sustain them at a local level. I'll give you a couple examples of those. One is a new program, actually. One of our new sites is actually in North Carolina, in Fayetteville, called Scouts. Can never remember what it stands for, but it's a great acronym. But it uses what we call intermediate care technicians. Intermediate care technicians are medics. So it's both a workforce program because you can come with your, expertise from the military as a medic, get right into this position, and then you work in an emergency room to provide supportive services within an ER, which medics are very well trained to do, but also to do home visits to rural veterans. And that's something that has been tested. It was actually started in San Diego and Grand Junction, Colorado. They figured it out in both an urban and a rural environment, got it to work, and now we're spreading it nationally. So that's the kind of ways that we take innovation and with our funding are able to spread them, but we also spread them with the intent of sustainability. Because one of the things I'm sure we've all learned with funding is if you fund something for a few years and there's no plan for it after that funding goes away, those programs oftentimes just die on the vine. And it's an unfortunate reality. Sometimes it just happens, but we try to plan ahead and say, how would this be funded if our funding ended in 3, 4, 5 years? So those are just a
Thank
couple examples. Shelley, can I
you.
say one thing on what you said about the pantry, the food pantry work with the local faith
Sure.
community? I'm glad you mentioned that because we have a longstanding rural clergy program,
Yes.
and it's now turning next year into a national program. It's funded by or maintained by the National Clergy Office, and I'm going to follow up after we're done here and get them connected with our food security people because another great way to bring things together at a local level.
Yes, VA chaplains were involved in the very early development of our program.
Cool.
Yeah. I want to shift because I see time is going very quickly. And I'd like to get guidance from everyone on the panel about effective cultural competency practices. Veterans have their own cultures, of course, and veterans in different parts of the country also have different kinds of cultural practices and values. So, Steve, why don't we start with you? Can you talk a little bit about overall practices to respectfully and effectively connect with tribal veterans and help us learn from your experience in how your organization has grown its relationship with this community?
What I will say is again, trust, trust is the name of the game. The other thing is that even though we were, um, you know, building the coalition and developing the coalition from the start, we were never in charge. We always let the local organizations be in charge. We worked with some amazing organizations like the Dene Nasma Partnership. We worked with, which is awesome, and I probably am brutally pronouncing this, but it's called the Chi for Che organization, which means wood for grandpa. And so on the Navajo Nation, Navajos have all licensed to be able to chop down trees. And so some of the younger Navajo chop down trees and cord it for the elderly who do not have firewood. And again, that is their source of heat and cooking. And so they do amazing jobs. We work with other organizations. We brought in the VA mobile units, the Navajo Nation Veterans Administration, each chapter house that we worked with. So really, they know their community and they know culturally appropriate identifications to honor the tribal customs and culture without us walking in and just stepping on everybody's toes. So we really let the local folks lead the charge, and we try to bring the resources together that are missing in those different uh, resource events. The other thing from a framework standpoint is that in order to receive all the food and water and wood and clothing and whatever we had to give out on those resources, they would first have to go through the resources or with all the different organizations and kind of get checked off. They would give us their contact information, and the Dene Nasba Partnership would reach out to them and follow up with them, to try not to just have this be a one and done handout, that we could actually establish a relationship, get them, if they weren't registered for the VA, get them registered for the VA. That follow up was very important. Culturally, what I will tell you is one event that we had a solar eclipse. Um, right during when we first got started, and the community said, could we please shift and start later in the morning, so that we can be at home, and have the eclipse pass, which is in our culture, right? To Peter's point, during COVID, we had a beautiful assortment of USDA food boxes. Um, and so we chose the food boxes that were traditional, and we actually had some mutton stew, which is a huge hit on the Navajo Nation. So the USDA gave us mutton stew, fresh vegetables, other areas. But afterwards, when the USDA program stopped, we wanted to continue to do food boxes. And what was told to us was they have what's called a sheep herder special. And a sheep herder special is traditionally a welcome basket, that they give to one another on the reservation. It's a traditional basket made, and it has Navajo flour, and it has lard, and it has coffee, and it has uh, um, uh, potatoes, water, spam. And so traditionally, that's a non-perishable amount where they can make fry bread, have protein, make coffee, have potatoes, and it lasts them a good week. And so that's what we started doing, is we started working on sheep herder specials. And so we would hand them out. And it was, like you're saying, it was observing the customs and traditions, and it was something familiar to them. Uh, and items that were familiar to them. So I think that was a wonderful way of learning. And the way that we learned was that we just kept our ears open, to be able to find those wonderful connections, as we're trying to do our work.
Thank you so much. So, Peter, you faced the challenge of having to be kind of both global and local at the same time. How do you deal with these issues of cultural competency? What have you learned about from your vantage point?
I'll give three sort of examples. I think the first is there have been attempts at training. I think the challenge with training and especially mandatory trainings is it's a really it's a sledgehammer to a finite problem, and it doesn't necessarily improve the providers or the healthcare providers cultural competency by forcing them to sit and click through a training. So, we don't, our office hasn't taken the approach that training is going to solve it. What we've tried to do is get back to, again, what is that local need? I'll give you two very concrete examples. So the first one's in Puerto Rico. Only about 5 to 10% of veterans in Puerto Rico are technically rural, but if you've been to Puerto Rico, there are some very rural parts of Puerto Rico. Uh, and what's unique about the population there, even though the veterans all speak English, many of them choose to speak Spanish. So ensuring that we have the materials, the signage, things at the clinics and the hospital in San Juan that are appropriate for people who choose to speak Spanish. The same as the programs that we have that bring the care to the veteran in Puerto Rico. We want to make sure that it's appropriate for what they want to have. The other populations, as Steve's been talking about, the American Indian Alaska Native population is, and this building of trust. We just started last year, but a program at the Prescott, which is in northern Arizona, the Prescott VA, with a rural native navigator program. So it's hiring somebody from the community who is a veteran to navigate the care between VA, Indian Health Service, local tribal entities, and what are the resources locally. And that program took us 5 years to develop. And that was with a group of people that had already been working for 10 years on various American Indian issues in the Southwest. And so it takes a while to build that trust. It takes a long time to determine what the needs are. But now we're expanding it to Iron Mountain, which is in the Upper Peninsula of Michigan, and in Northern California. So the goal is that this is again a program that our office has developed in partnership locally, but then tailor it to the needs regionally.
I want to make sure there's time for the question I'm going to ask next, and there's still some others that I hope to get to, but I really want to give us a few moments to focus on the needs and issues related to women veterans, one of the fastest growing populations within the veteran population. And there's been lots of evidence to suggest that women have, I'll say, uneven experiences in their interactions with others as veterans. Have any of you had experiences or insights that might be helpful to our audience that you would like to share? Tim, you're smiling. Does that mean you have something you'd like to say?
In North Carolina, particularly, I can't speak for other VISNs. In my community, Onslow County, which outside of Jacksonville, North Carolina, is extremely rural. It's very, very uh, open. Up until probably about two or 3 years ago, there was no women's clinic, no VA women's clinic in Onslow County. So women in Onslow, Pender, and the surrounding counties all have to drive to New Hanover County to access women's health services if they wanted to. And I'm going to use the line because Peter's on, choose VA, right? So we hear that all the time. We want veterans to choose VA. And I will say the VA has started to recognize, right, where the veterans are geographically dispersed. And I recently there became another women's clinic. There's one in Onslow County. So those veterans are no longer having to drive an hour and 15 minutes to receive VA women's health care. I think that, and I saw it come up in the question and answer, right, in terms of like VA's ability to get community providers on board throughout their community care network is difficult. And I think that's ultimately always going to boil down to reimbursement, right? So we're doing decent here in North Carolina.
Steve, you raised your hand. Would you like to say something about women veterans?
Yeah, just to dovetail on what Tim was saying, I know that a lot of female veterans don't really engage in a lot of the VA events because they feel, I think the MST kind of pervasively clouds a lot of that, and so they don't necessarily like to get back into that atmosphere. A lot of people just assume, and I see it all the time when you're at veteran events and they say, "Oh, did your husband serve?" And it just drives female veterans crazy, and so a lot of times we try to do veteran female specific events, but that gets hard to do in the in the rural areas. I will say that our Navajo female veterans are just a joy. They're passionate. They work so hard, and they really are the foundation of many of our events. Because without them, uh, you know, again, they're kind of the nag factor for their husbands to get out and get into those events and get the resources that they need. But I just want to kind of dovetail into that because
Thank you.
there's a lot of specific female veteran issues that we need to take a new approach to, or maybe some innovative approaches to.
I have a couple of my staff members that are currently watching this call, so I'd be remiss if I didn't um, call them out. So I'm fortunate to where I have two female Marines on staff who work within my program. Braden and Taylor, I know y'all are watching, so hi. Every veteran, every person wants to get care from somebody that looks like them and has similar experiences like them, right? So as we talk about cultural competency and we move into women veterans, it would just make sure organizationally that you are uh, making your hiring processes intentional, right? Who can I hire in those communities or that comes from those communities that may already possess those relationships, and you're going to save yourself a lot of headache down the road, right? And so just making sure that you have a diverse workforce is important.
Um, I want to make sure that we also address the issue of transportation. Um, it came up a little bit early on, sometimes because of distance, sometimes because of access to vehicles, sometimes because of other things. Um, what is your organization, what are your organizations or communities trying to do to lessen this burden or meet rural veterans where they are? Peter, do you want to start with sort of how it looks from the national view, and then maybe Tim, Tim and Steve, you've both talked about this a little bit, but maybe you'd like to add some additional thoughts.
And I think goes back to one of the things I said early on. It's a two-way street in terms of transportation, in that what can we bring to the veteran in their home or closer to their home, and what do we need to transport them for, or what do they need to be transported for? Nobody, I mean, none of us included, want to drive to a clinic appointment, park, go there, and then just talk to somebody that you could have just done over the phone or could have done by video. So if you don't need to be present, let's keep the care closer to the veteran. To get them there, we have sort of three main ways. One is we do have our beneficiary travel, and we could talk for a long time for everybody who's familiar with Benny travel in the VA. It's kind of complicated, but about 50% of veterans are eligible for beneficiary travel, meaning they get paid mileage to come in. And so, but only about half of them actually use it, because you may be eligible, but if you've got a 20-minute drive, by the time you want to fill out the online form and get your reimbursement, it's for $8. Most people, half people don't even bother. But it's available for people who the cost of just going 10, 20, 30 miles is a barrier. The second is our veteran transportation service that we help fund, and they partner with veteran service organizations. So the DAV vans and American Legion vans, they partner with them, but then we have our own vans that we purchase, and they do hundreds of thousands of miles of trips every year. And again, not everybody uses it, but those that need it is a lifesaver. And then, so those are the two main ways. I'll stop there.
Great, thank you. Steve, would you like to add anything?
For transportation, I think it's, I feel like my example of the Navajo Nation is more of the fact that they as a community are trying to to coalesce themselves and collectively understand who's being missed out, but that's not a fail safe. What I will say is that here in Eugene and in Lane County, we are managing our stand down on September 27th, and we've teamed up with because Lane County is a very large county, goes from the mountains to the ocean, and but we've partnered with Lane Transit District, and so on the stand down, they will offer free bus shuttles to any veteran or family member, no matter where they are in Lane County. Free bus service to and from the stand down, and so that's an interesting kind of partnership that we can make here locally. But I'm sure there's much more creative ways that can help the transportation.
The audience members would like us to return to the issue of the digital divide. And I was struck by what you said earlier, Peter, because my institute recently did a policy brief in partnership with the Purdue Center for Regional Development, which tracks the digital divide. And one of the things we learned was exactly what you said. It's kind of a three-legged stool. You need infrastructure. You also need affordability. People have to be able to connect to that infrastructure, and you also need accessibility, which means they know how to use it and they're willing to use it. So as you look at what you see around the country, how would you organize what needs to be done, or what the priorities need to be in terms of the three legs of the stool?
Yeah, so if you asked me this question 2 years ago, I would have said, the American Broadband Initiative, in terms of getting broadband into rural communities, was so vitally important. It still is important, but with the advent of low Earth orbit satellite, not advocating for any of the companies that do it, but the 100% of the United States, actually maybe 99.99%, there's a couple pockets that don't have access, for example, to Starlink, has changed the atmosphere completely. So example, I was in Alaska And now there's no reason to put cable broadband into the interior of Alaska. It makes no sense. But everybody now can get access to Starlink, and there will be others coming up. But it is a $500 setup fee, $100 to $120 a month. So there is costs associated, which then creates the barrier of costs. But I think that has made a huge step forward in the last 2 years. I think education and training and the access to that, the VA, we have resource centers that we're not at every VA yet, but we're trying to get them at every VA, that basically you can get assistance anytime with help with technology. You can walk in and have your iPhone and say, or your smartphone and say, how do I get this app on here? And I think third is, there still is a lot of people use surrogates, caregivers, as another means to overcome that barrier. But it's kind of all hands on deck.
I think this concludes my role in today's session, and I'll turn it over to Macy.
Hello, everybody. Thank you so much to Shelley for moderating today, and to all of our panelists for your participation in this discussion. We've gotten a lot of great questions from the audience. And so what I'm going to do is send some of these questions to our panelists to answer offline. And then we will include some of their answers in our follow-up email. That email can be expected within the next week, along with the webinar recording and some of the resources mentioned here today. You can share all of those resources and recordings with anyone in your organization or your community and network. We highly encourage that. But I also want to plug quickly before we leave each other today that 54% of rural veterans enrolled in VA's healthcare system are age 65 and over. And our next webinar on October 17th at 2 p.m. Eastern will tackle the topic of addressing the needs of aging veterans. So there will be a little bit of overlap there, and also a lot of specific focus on other issues affecting aging veterans in urban areas and so forth. So we hope that you can attend that one if it's relevant to your work. I will include the registration link for that in the follow-up email as well. And thank you everyone for your time today. And again, to our panelists and our moderator. And
Thank you very much, Macy. And I neglected to thank the other panelists. It was such a pleasure to learn from you today. Thanks so much.
thank you everybody for attending, and we will see you next time.